Hi, I'm David Cunnington. I'm a sleep physician, and assessing sleep problems in people can be really tough. I find it tough. This is what I do every day. But even then I find it hard to often tease out all the different components that are going on for a given individual when I'm trying to assess their sleep problems. So I'll talk you through a framework I use both in conceptualising the different sleep disorders as well as thinking about how different neurotransmitter systems and systems involved in the regulation of sleep can be mapped to the clinical symptoms that people get and therefore put together a plan for management. When I'm trying to assess someone with sleep symptoms, one of the things I'm thinking about is what particular sleep disorders may they have that may be adding to their symptoms. And for most people there's actually more than one sleep disorder. So a useful way of trying to categorise the sleep disorders is using this framework. So conceptually we can think about one of the problems being not getting enough sleep. So think of that as lifestyle factors, insomnia, people just not allowing enough time for sleep, versus insomnia, whereas people allow enough time, wish for sleep to come, but it just doesn't come and fill that space. So people just not getting enough minutes of sleep per 24 hours. The second group of sleep disorders, think of that as sleep quality not being adequate, which can lead to feeling tired or sleepy. And sleep apnea is the classic version of that, where repetitive breathing disturbances during sleep result in fragmentation or disruption of sleep and therefore feeling tired. But there are other disorders that can cause that too, such as restless leg syndrome or periodic limb movement disorders via repetitive movements. And also too in people, particularly with mental illness, I can see subthreshold anxiety or physiological hyperarousal causing issues with sleep quality. It's not necessarily causing insomnia, but people may feel that sleep is light, a bit lighter than expect it to be, and somewhat non-restorative. The next category is things happening during the night. So think of that as parasomnia, so sleepwalking, sleep talking, nightmares, distressing dreams, night terrors. Anything that occurs like that during the night will often tend to make people feel sleepy during the day. And we get a history about those things, not just from the person who's experiencing them, but also from observers such as bed partners. The next category is sleep not at the right time. So the circadian clock has a very important influences on lots of body functions, including sleep and mood regulation. And although we may wish to go to sleep at a particular time, if our body clock isn't in sync with that, we'll have difficulty getting to sleep or potentially difficulty getting up. Circadian rhythm disturbances are very common in people with comorbid mental illness, so this is a common thing I see in a lot of patients. And there's a group of conditions where people are too sleepy. So despite getting enough sleep, sleep's good quality, there's not much going on during sleep, and they're sleeping in the right circadian phase, they still feel excessively sleepy during the day. And we call that group of conditions hypersomnias. So once I've considered different sleep disorders in a given individual based on the framework that I've just discussed, I'll then try and think about which biological systems and brain systems are involved in their sleep symptoms or their sleep presentation. And I'll just talk you through some of the neurotransmitters, and then I'll bring it back to a systems-based approach which allows you to then map it better to clinical symptoms. The way sleep's regulated, and we certainly don't know all of the answers, but we know that there's an intrinsic body clock that's very important in regulating wake and sleep, as well as a lot of other bodily functions. Light's a key player in regulating and resynchronizing the body clock, and melatonin is part of that pathway, sort of one of the modulators between light and the actual body clock. We're not sure what the neurotransmitter or the pathway is that transmits signals from the clock directly to the sleep controller mechanism, but we know orexin's one of the key neurotransmitters in regulatory control of sleep. Orexin mainly promotes monoamine activity and the alertness or waking system, but can also have a role with suppressing GABA activity or the sleep system, and also stabilising the relationship between sleep and wake. Narcolepsy with cataplexy is an acquired orexin deficiency condition, so they get symptoms of not feeling awake enough and instability of the sleep-wake boundary because of an absence of orexin. Now, the things that help us feel more awake are monoamines, so serotonin, histamine, dopamine, adrenaline, and the sleep-promoting system, that's largely GABAergic. So many of the drugs that we use that either enhance or block GABA are going to have effects on the sleep system. And another factor that contributes to the stability of the sleep and wake system is acetylcholine. In the presence of acetylcholine, we will preferentially go into REM sleep, and drugs that block acetylcholine will act somewhat as REM suppressant medications. One of the potent effects of most antidepressants, even the modern antidepressants, is the suppression of REM, most probably via their effects on acetylcholine. So taking that neurotransmitter or neurobiological model and then simplifying that into a systems-based approach, this is how I like to conceptualise sleep and wake regulation. So we have an overarching body clock, which then regulates the interaction between the waking system and the sleep system. And when I'm thinking about then treatments for patients, I find this a really helpful framework in trying to work out what may be the components to their symptoms and then what are some approaches I can use to help get them feeling better. Because what I'll do is, listening to the narrative history as well as thinking about things as I'm talking with people, I'll be thinking about what may be factors that are impacting on the body clock, what may be factors that are impacting on the waking or alertness system, and what may be factors that are impacting on the sleep system. And for each of those systems, I'll be thinking about what are behaviours that that individual is doing that may be impacting on that system, what's some of their thinking or belief structure that may be impacting on that system, and what's some of the physiology. Now, some examples of that. So let's go first to the wake system. So an example of the physiology of the wake system would be people that are just genetically predisposed to being a little bit more excited. You know, we all know people who are busy and busy bees and always that bit fidgety and twitchy. You know, I'm a bit guilty of that myself. But that's a physiological system that's much more likely to run at higher alertness levels. So naturally, it's going to be a system that doesn't switch off as readily at night. Another example of the physiology may be people who have early life trauma or significant trauma and PTSD, where neurophysiologically there are heightened levels of arousal and heightened levels of vigilance. So we know part of their sleep problem is going to be an inability to turn off the wake system. Thinking that's an issue with the wake system may be a thinking style. So a thinking style of a tendency to worry, personality traits of perfectionism, these all ramp up that alertness system. And behaviours that can ramp up the wake system are running on nervous energy all day. We wear it as a badge of honour in today's society that we're a busy bee and running on nervous energy throughout the day, but that's not pixie dust. It is actually noradrenaline, adrenaline, dopamine, sertraline, all those neurotransmitters that we're boosting up through the day that are going to mean it's harder for them to switch off at night. Taking that same framework to the sleep system, an example of that may be thinking around sleep. So if people have the commonly held belief that I need 8 hours of sleep per 24 hours, but they only actually really need about 6 hours of sleep per 24 hours, that belief is going to mean they spend 16 hours awake accumulating that homeostatic sleep drive and 8 hours burning off that homeostatic sleep drive. But for that individual, they may need to be 18 hours awake to accumulate enough sleep drive to get 6 hours of sleep. An example of behaviour around the sleep system, is it the same sort of thing? A mismatch between the physiological sleep need and the amount of hours in bed somebody is actually spending. So insomniacs or people with insomnia tend to do that. They're wishing for more sleep, so they spend 9 hours in bed wishing for sleep to come, even though physiologically they're quite hyper-aroused. They're only going to get around 5 or 6 hours of sleep. Bringing that to the clock system, an example would be physiology. So people with chronic illness for a range of different conditions tend to have impaired circadian sleep-wake regulation, so a flat amplitude of the circadian rhythm. We also know there's basic science work and clinical work coming out about the relationship between mood and the circadian system, with a tendency to a phase delay in people with mood disorders or some subtypes of depression. Thinking around the clock, it's very pervasive in our Western culture that, you know, an hour of sleep before midnight's worth 2 hours after midnight, and that we should be in bed by 10 and up by 6. And in clinical practice, when I ask people what time do they go to bed, they're often apologetic if they're going to bed much beyond 10, as they think I'm going to be judgmental and say, look, that's a bad thing. Whereas our individual sleep need, we all have our own genotype in terms of our body clock, and some people are late night types and actually suited better to going to bed later rather than being up early. So I hope you found that framework helpful in assessing people with sleep problems. Just to finish up, a couple of tips. I really love just listening to the way people talk about sleep, and really that gives me all the answers, because what I'm really looking for is their behaviour around sleep, how they think about sleep, their beliefs around sleep, and that's what comes out in the narrative. So if I give people the space to talk about sleep and get my ear in for listening for dysfunctional beliefs around sleep, emotional currency around sleep, that's often the secret. So listen to your patients, don't cut them off, and listen to the emotion around sleep. Now, the other thing to listen for when you're listening to that emotion around sleep is attributional bias around sleep. It's really common, and I see health practitioners buy into it and are often almost complicit in the attributional bias. And think of it as things like statements people may say like, if only I could sleep better, then I wouldn't have these other problems. Someone who's struggling with mood but also poor sleep really gets into that sort of cycle of, if only I was sleeping better, my mood would be fine. But then they ignore strategies for managing mood and they focus overly on the sleep, whereas in actual fact they may need a strategy for both. You know, I'm often on the receiving end of referrals from other specialists and, for example, rheumatologists and people with fibromyalgia who are told if only you could sleep better you wouldn't get as much pain and your fibromyalgia would be a lot better. Yeah, you know what? There may be something in that with the basic science, but it actually puts too much pressure on sleep and can ramp up sleep-related anxiety. So don't collude or be complicit with people's attributional bias around sleep, because otherwise you may miss out on managing other important aspects of their illness. So I hope you found that framework helpful and it's something that you're able to incorporate into your clinical practice. If you're looking for more information on assessing sleep problems, you can check out the Mental Health Professional Network webinar at the link below. And there's also more information at sleephub.com.au, which has a range of resources both tailored to people with sleeping problems and to health professionals who are looking after them.
For the A to Z of sleeping well, head to the Hub, sleephub.com.au.